My name is Elizabeth Messmore, and I am currently a FNP student at Maryville University. Today I will be completing my head-to-toe assessment. This is my patient Brian. Before we entered the room, I had him empty his bladder and change into a gown. I washed my hands. We obtained a set of vital signs as well as a height and weight. We checked his distant vision using the Snellen chart and his near vision using the Rosenbaum chart. We also tested for a sense of smell. So now I'll begin my head-to-toe assessment, starting with the head and the face. Looking at the face for inspection, I'll look at the eyes and the ears, making sure they are symmetrical and in the right place on the face. Looking at the nose and the mouth, making sure they are both midline. Then I will begin to palpate his scalp and his hair, making sure his skull is normal cephalic, and looking at his hair for even hair distribution, softness, and non-brittle areas. Next, I'm going to move to his frontal bones of his face. He's going to let me know if he has any pressure or any pain.
No pain.
Great. Next, I'm going to move to the sinuses, the frontal and maxillary sinuses. I'm going to give you some pressure. Tell me if anything hurts.
No. No.
Great. Next, we're going to move to the TMJ. We're going to test it for any popping or clicking, and I'm going to have him tell me if he reports any pain while we do so. Open your mouth and close. Good job. The next thing we're going to assess for then would be light sensation. So we're going to have him close his eyes. I'm going to grab a Q-tip and we're going to touch him on, tell me if you can feel this on both sides or one side or more than another.
Equal. Equal. Equal.
Great. Next, while we're here, we're going to test for his cranial nerves. We're going to have him stick out his tongue, smile, puff his cheeks, clench his teeth, squeeze his eyes shut, and wrinkle his forehead. All right, moving on. So we're going to go to the eyes. We're going to inspect the eyelids, the eyebrows, and the eyelashes, making sure that the eyelashes and the eyebrows have even hair distributions, that the eyelashes fan outward, and that the eyelids open and close without difficulty. Next, we're going to look at the conjunctiva, making sure that it is pink and moist without any drainage or edema. And as well, at the same time, look at the sclera and make sure it is nice and white with no yellow discoloration and little redness. The next thing we're going to do then is palpate the eyes, the eyelids, and the lacrimal apparatus, feeling for any nodules or any pain. And there is none. So then we're going to move on to our eye test. Using we're going to check his pupillary response using my pen light, using direct and consensual. So first will be direct. Take a look at my nose here. And now consensual. Great. The next thing we're going to look at is for the red light reflex. So I'm going to have him look into my light, and we're going to look for a red reflex in his pupils. Great. The next test we're going to do is the confrontation test for peripheral vision. I'm going to put my arms out inside you. Tell me you can see my fingers.
Now.
Great. The next thing we're going to do is a test for extraocular eye movements using the 6 cardinal fields of gaze. So I'm going to have him look at the tip of my pen light. He's not going to move his head, but just keep his eyes moving on the target. And as well, testing for accommodation. Great. The last thing we're going to have him do is cover and uncover. So we're going to have him cover up his right eye. I'm going to do my hand over here, show my hand movements.
1.
What numbers am I holding
2.
up?
3.
And cover the next eye. And we're going to check for any extraocular eye movements or strabismus during this time.
3.
Great. So moving on from the eyes, we're going to move on to the ears. Looking at the ears of inspection, we're going to make sure they are even in alignment. They are positioned in the right part of the head with no deformities. We are going to palpate the auricles for any nodules. Those feel great. And we are also going to do a set of hearing tests on him. The first is going to be the ear canal and the tympanic membrane. I'm going to get my otoscope. And we're going to check the ear canal for any earwax. We hope to see little to no earwax. Looking at the tympanic membrane, that it's nice and pearly and gray. There's no bulging or perforation or drainage to the ears. Great. The next thing we're going to do then is the whisper test. I'm going to stand behind Brian, and I am going to whisper a couple words to him, and he's going to repeat them out loud.
Apple. Orange.
Great. The next thing we're going to do is the Weber test using our tuning fork here. So we're going to strike the tuning fork, and Brian's going to tell me if he can hear the sound equally on both sides.
Equally.
Great. We are going to then finish with the rind test. We're going to again strike the tuning fork and place it on his mastoid bone. He is going to tell me when he can no longer hear the sound.
Now.
And we're going to move it in front of his ear and tell me when you can no longer hear the sound again.
Now.
Great. So air conduction should be twice as long as bone conduction. It's important to watch the clock during that as well. So then going from the ears, we're going to head to the nose. Looking at the nose here, we're going to look at the bridge of the nose, making sure it's midline. The nose is midline on the face. If the bridge of the nose goes straight. We're also going to check for any kind of deviation in the nose that could be shown externally. As well as look inside the nose. We want to look up at the mucosa, making sure it's nice and pink and moist. We want to make sure that there's no septal deviation or perforation, and we want to make sure the turbinates are clear. Everything looks good. So next we're going to palpate the nose to make sure there's no pain, no tenderness, no masses. And then lastly, we're going to have Brian check for patency, so he's going to cover one nostril with his finger and breathe in. And the other side. Great. Next, we're going to flip over to the mouth, looking, inspecting his lips first, checking for any cracks or fissures that might be present. And then we're going to look inside the mouth with the light, looking at the buccal mucosa, making sure it's nice and pink and moist, looking at the gums, making sure they're not edematous and pale, looking at the soft palate and hard palate on the top of the mouth, as well as the roof of the mouth under the tongue. Everything looks great. We are then going to move on to the oropharynx. With that, we're going to take a deeper look inside. We're going to look back and investigate the anterior-posterior pillars, the uvula, which is midline, the tonsils, which are nice and small with no exudate, the posterior pharynx, which is nice and pink and moist, and lastly, any odor that could be coming from his breath, which there's none. Next, we're going to look at his teeth. The number of teeth, the color of the teeth, nice and white, and then also the surface characteristics of the teeth. We want to note any cavities, any molars, any wisdom teeth, or any tartar on the teeth. Next, we're going to go to the tongue. We're going to have you stick out your tongue. Look for color, consistency, symmetry, and movement. So we're going to have you lift your tongue up, lift your tongue down, and right and left. Good job. And the tongue is nice and pink and moist. The last thing we're going to do then is do the gag reflex and the reflex. So we're going to take the tongue blade and gag, and then we're going to have him say ah. Great. So next we are going to move down into the neck, looking at the symmetrical expansion of the neck and the thyroid, making sure that he has no jugular venous distension on either side, any pulsations. At this time, we're also going to take a peek at anything that could be obstructing the JVD also. So then we're going to move on to the range of motion of the neck. So we're going to have him, which is another cranial nerve, lift his shoulders. And then we're going to have you put your chin to your chest, head up and back, ear to your shoulder, ear to your other shoulder, look right and left. And I'm going to have you push this way and push this way. Great. So the next thing we're going to do is palpate the neck. We're going to start with the carotids. We're going to palpate only one side at a time. Nice and strong, good pulses. We are then going to palpate the trachea, making sure it is nice and midline and not deviated. And then lastly, we're going to have a mix in the neck up, and we're going to test the thyroid. We're going to take a big swallow. It's nice and in place for us. The last thing we're going to do for palpitation of the neck is do the lymph nodes. I'm going to do the full set lymph nodes here. So we're going to start with the preocular, the postocular, the occipital, the submandible, the submental, the tonsillar, the superficial cervical chain, the deep cervical chain, the posterior cervical chain, the supraclavicular, the infraclavicular, and the axillary. So that will conclude our neck assessment. We are now going to move on to the anterior chest. We will assess mostly the heart and lungs. during this assessment. But first we want to inspect the chest, look for any obvious signs of rashes, lesions, deformities, make sure his nipples are midline, his hair pattern distribution is normal, his clavicles are nice and straight. We also want to note his breathing, note that he is not using any accessory muscles, abdominal use, he has nice, uneven, regular breaths, and he has no pulsations or heaves either. So moving on, we are going to palpate the chest. So palpating the chest wall to feel for any masses, nodules, or lesions. Everything feels great. Next we're going to palpate for precordium. So feel for any heaves, thrills, or lifts of the chest. Sounds good. Feels good. And then next we're going to move over to the apical pulse, which is the left intercostal space. And it feels great. The last thing we're going to do is check for tactile firmitus. And for this, I will be asking Brian to say 99 when I place my hands on his chest, and we're going to feel for vibrations.
99, 99, 99, 99.
Great. The next anterior chest assessment we're going to do is percussion. With that, we're going to percuss in a systematic way from top to bottom and right to left. Testing for resonance known in the lungs. If we do hit dullness, it will only be in the organs. That sounds great. The next thing we're going to do is move to auscultation. So I'm going to auscultate then his lung sounds, starting from the right upper lobe and moving down systematically once again. Now you take some deep breaths for me. Great. His lung sounds are nice and clear for us. The next thing we're going to do is listen to his heart sounds. This can be done with the bell and the diaphragm of the stethoscope. For timing purposes, I'm just going to use the diaphragm of the stethoscope. And we are going to be listening for any gallops, clicking, rubbing, or murmurs. So starting in the aortic, moving to the pulmonic, moving down to Erb's point, and then tricuspid, and mitral. Great. That concludes our anterior chest. We're going to flip them around and go to the posterior chest now. If you want to drop your gown back. So again, once again, we're going to be looking and inspecting the posterior chest. Just like the anterior chest, we want to look at the skin, look for any rashes, any masses, any abnormalities. Make sure his shoulders are even here. Look at his thoracic configuration of his body. Next, we're going to move on into palpation, and we're going to start with expansion. So I'm going to take my fingers like a W, place them on his back in the 10th rib space, have him take a deep breath in and out, and he does have symmetrical expansion. Next, we're going to test for tactile firmitus, just like we did on the anterior side. So I'm going to have you say 99.
99.
99.
99.
99.
99. 99.
Great. And we heard vibrations throughout. Next, while we're here, we're going to check for CVA tenderness at the kidney. So tell me if you have any pain.
No.
Any pain?
No.
Great. The last palpation we're going to do on the posterior chest is going to be the spine. So I'm going to palpate the spinous process just to make sure there's no abnormalities in the upper chest. And that looks great. So the next thing we're going to do, much like the anterior chest, is percuss again in the systematic fashion from up to down, right to left. Again, we should only hear resonance. And no dullness. Great. And then we are also going to check while we're here for diaphragmatic excursion. So when we do diaphragmatic excursion, we're going to percuss down along the scapular border. What I'm going to have Brian do is take a couple breaths, take a deep breath in, and blow it out and hold it. Do that now. And I'm going to percuss down until resonance turns to dullness. I'm going to mark that spot. And then I'm going to let him breathe normally again for a couple breaths. And then I'm going to palpate the same way, but I have him take a deep breath in this time and hold it in. And then once again, percuss down. Again, where resonance turned into dullness. So should be about 3 to 5 centimeters apart here. I'm also going to percuss laterally. You don't want to forget the lateral aspects of the lungs, so you want to percuss laterally. And that sounds great. Moving on to auscultation of the posterior chest, we're going to listen to the lung sounds posteriorly in the same fashion from right to left and top to bottom. Deep breath. Deep breath. Deep breath. Deep breath. Great. That concludes, oh, don't forget the lateral sides too. So we're going to auscultate the lateral sides as well. Great. So that concludes our posterior lung and posterior chest assessment. We're going to have him flip around and lie flat for me. And we're going to do our abdominal assessment. We're going to have him pull his knees up just so he can let his abdominal muscles relax. We're going to first check out, assess the abdomen, looking at the belly and making sure that there's no hernias, any masses, any lesions. Also noting any that the umbilicus is midline, as well as it's smooth and with breathing and round and with movement. Next, we're going to test the contour, which will be his stomach is pretty flat. So we want to shine our light to make sure there's no visible peristalsis, no surface movement or motion, and the movements are smooth and easy. Next, we're going to have him take a deep breath in and hold it. And the contour stays normal, which we note it should not change. And let go. And next, we're going to have him lift his neck. And again, the contour stays normal. It should not change. Next, we're going to have him straighten his legs. And we're going to assess the abdomen. We're going to percuss the abdomen. This is going to be in all 4 quadrants. And we're going to listen for tone of percussion. It should be resonant in sound. You can hear tympany as well, but never dullness in the abdomen unless it's over an organ. And his percussion sounds good. We're going to also look at his splenic border with percussion and his liver border and his splenic dullness. So we're going to go from the right midclavicular line, and we're going to go midway down, and we're going to percuss down until resonance changes to dullness, and we're going to mark that area. Then we're going to percuss up, the same thing, until resonance changes to dullness, and you can see you have your liver border there. The other one you're going to do is splenic dullness, and you're going to check from your mid-axillary line posteriorly, and you're going to percuss in different angles around to check for dullness of the spleen, which you will hear dullness in the 6th to the 9th rib. Great. Next thing we're going to do is auscultate the abdomen. We want to listen for the vowel sounds. Using the diaphragm of the stethoscope, just listen in all 4 quadrants. And using the belt of the stethoscope, we are going to auscultate for his abdominal arteries, starting with his aortic in the middle. Listening for any bruits. Going to the renal, which is done bilaterally. To the iliac, which is also done bilaterally. And to the femoral, which is also done bilaterally. Great. Next, we are going to move on to palpation of the abdomen. We're going to lightly palpate all 4 quadrants first. So tell me if there's any pain or tenderness.
No.
Great. You can also deeply palpate the same manner in all 4 quadrants as well. Next, we are going to do deep palpation to a couple of his internal organs in the abdomen. So the first is going to be on the right costal margin of the liver border. We're going to have Brian lift. I'm going to lift his back on his left side between the 11th and 12th rib, and I'm going to push down and deeply palpate his liver border. And it does not feel enlarged. It feels nice and a nice clean liver intact. And then we're going to move over, and we're going to, on the left costal margin, we're going to deeply palpate the spleen. So with this, you're going to take your left hand and lift and deeply palpate with the right. And the spleen should never be palpable. And the next one we're going to do is going to be the kidneys. It's done bilaterally. For time purposes, I'm just going to do the left side. So I'm going to lift up at the costovertebral angle on the left, put my hand down, and I'm going to palpate that kidney. The kidneys are palpable. The next thing I'm going to palpate will be the abdominal aortic pulsation. So it's just midline to the left a little bit of the abdomen. You're going to deeply palpate for that pulsation there. All right. And the last thing I'm going to palpate for is going to be your abdominal musculature. So I want you to tell me if you have any pain or tenderness with the deep palpation. Just pushing on those muscles, making sure he's got no hernias, anything going on.
No pain.
Great. All right, so now I'm going to have you sit on up. We're going to move back around and we're going to do the upper extremities now, looking at the shoulders, elbows, wrists, hands, and fingers. Looking at the skin mostly, making sure there's no rashes, no lesions, no deformities, no abnormal nevi that don't fit the ABCDE qualifications. We're also going to look for any bone abnormalities, any hair redistribution, any muscle atrophy at this time. And since everything looks great, we're going to move on and check his brachial pulse, which is 2+, and his radial pulse, which is 2+. We're also going to check his fingers for capillary refill, less than 3, no clubbing, no cracking, and no spooning to the nails either. The next thing we're going to do is check your mobility. So I'm going to have you push down and push up. And put the hands out, hands down, and hands up. Good job. 5 out of 5 mobility and range of motion to the arms. Next, we're going to check his reflexes. Starting just on the right side, you can do both of these things on the left. We're going to check the bicep reflex. Good. We're going to check the brachial radial reflex, which is extension of the thumb. And we're going to check the triceps reflex. Good. Everything looks great. The last thing we're going to do with the upper extremities is test for dullness and sharpness of sensation. So I'm going to have Brian close his eyes. Tell me if you feel dull or sharp.
Sharp, dull, dull, sharp.
Good. Moving on to the lower extremities, we're going to assess the thighs, the knees, the legs, the ankles, the feet, and the toes. Here, same exact thing as the upper body. We're going to be checking for any abnormal nevi, any rashes, any lesions, any skin discolorations. We're going to be checking, especially on the lower legs, for any edema that could be present, temperature changes in the legs or feet, any skin turgor problems, and any hair distribution, any muscle atrophy or bone deformities as well. So moving on, we are going to check the cap refill of his toes, making sure he has good perfusion to his feet, and no clubbing or spooning or cracking to his nails. We're going to assess his pulses, so his popliteal, which is 2+, his posterior tibial, 2+, and his dorsalis pedis, which is 2+. And then we are going to next assess his strength of his thighs and feet. So we're going to have him push up on my hands. Good. And push down on my hands. Good. And we're going to have you push down on my hands. Good. And up on my hands. Good. So then we're going to assess his deep tendon reflexes also on his lower extremities. Like I said, on the upper extremities, it can be done both sides. We're only going to do the one side for time purposes. So checking the patella. And checking the Achilles. Great. The last thing for the lower extremities that we're going to do is going to be the sharp and dull sensation. So we're going to have you close your eyes again and tell me if you feel deep or sharp or dull.
Sharp, dull, dull, sharp.
Great. All right, moving on to our last assessment, which is going to be our musculoskeletal assessment. We're going to have him stand up in front of us here. And the main thing we're going to look for here is going to be his back. Turn this way towards the camera. Look at his back, making sure this like the anterior chest, that there's no, that his shoulders are midline, his back looks good, his spine is straight, and then we're going to look at his thoracic spine that is convex and his lumbar spine that is concave. So those are both good things. We're going to have him do a couple things for range of motion purposes. So we're going to have you, I might have to turn this way now, bend down and touch your toes, noting the spine, okay? Stand up. Bend back at the waist, good. And then touch side to side with your knees, moving that spine around, making sure it's still no popping, no clicking, no pain for him either. The last thing we're going to have him do is hula hoop and rotate his hips around. We should know his hips and his spine are intact. Great. So that concludes my musculoskeletal exam, and this also concludes my head to toe assessment. Thank you.